Welcome, students, to the lesion on skin disorders. Get it? Lesion? Well, okay, welcome to the lesson on skin disorders. Before we begin, I have to tell you this really funny story. A long time ago, I had a cancer patient who is receiving antibiotics, anti-epileptics, and chemotherapy medications. His wife actually called me in to come and look at this new rash. When I came in, the rash that I saw was on the back, and there was small red papules starting at the patient's shoulders going down to the patient's lumbar area, and I would say they were distributed pretty well between the right and the left side. See this picture here? This is pretty much what it looked like. I was not sure what was amiss, but I stopped the antibiotic and searched the body for any other systemic rash findings. Turns out it was only on the back in the shoulder area. I know it wasn't here on my AM assessment, and he hasn't come into contact with anything. He's been on antibiotics for a few days. He has no history of shingles and no drug allergies. I don't know. The two ideas I had in my head were, okay, so he got exposed to shingles somewhere in his hospital stay, and or I just caught this delayed drug reaction early. So I called the doctor, and I'll never forget what Dr. Sonnenberg said to me and how we worked through the situation. Turns out Dr. Sonnenberg was just leaving the hospital when he got my page. My description over the phone of my findings was kind of vague and something like this. Dr. Sonnenberg, the patient has small bumps from his shoulders to his buttocks. And then Dr. Sonnenberg says, okay, are they itchy? Oh shoot, I have no idea. And then he goes, are they painful? Eek! I don't know that either. I didn't ask. And then he asked me, do they follow a dermatome? Derma what? And then he goes, are they in patches, or is the spread diffuse? And then he said, is there an even spread with maybe clusters? Dr. Sonnenberg, I did not study those at all. I don't know. Dr. Sonnenberg, I feel like it's a drug reaction or shingles. And of course, as you can imagine, Dr. Sonnenberg was not buying my assessment. So he got back out of his car and came back into the hospital. When he came to the unit, he said, you, come with me. And we walked together into the patient room, and he did a full body assessment. And then he turns to me and says, define skin manifestations of a drug reaction. Ugh, okay, so I rattled off Stevens-Johnson syndrome. And he says, no, I mean definitions, describe that. Looking back, I honestly did the best I could, and I came up with something like, okay, blisters and erythema everywhere. He said, all right, well, ask me, he then asked, define shingles. Oh God, this was getting harder and harder. I pointed out how these shingles could look like small vesicles, but I think my patient possibly had it because maybe I caught it in the beginning stages. And then he said, nope, vesicles will look like a vesicle from the start, and it will most likely be unilateral. Okay, but turns out my patient did report itching, no pain though, and itching is a sign of shingles. Okay, Dr. Sonnenberg was still not buying my diagnosis, and then we had some more discussion about the differences between macules and papules and pustules. He finally says, all right, Dr. Tonus, what is your diagnosis? Yes, I was a nurse, by the way, so that was sarcasm. I confidently replied, shingles, but the unusual case where the distribution is diffuse and bilateral. There is itching present, which is a characteristic, but these aren't the painful type because my patient has a high tolerance to pain per his wife's report. Dr. Soderberg then said, well, what's the treatment? I replied, I would give this patient a cyclovir because it is caused by herpes zoster, and that is a virus, and my patient is immunocompromised, so we should start ASAP. Dr. Sonnenberg kindly looked at the patient and says, we would do that for shingles, but unfortunately, you don't have shingles. This is prickly heat. Your patient, who has had fevers on and off his whole hospital stay, now has dried sweat and blocked sweat glands on his back, and he needs to get out of bed, have a shower, and get his sheets changed and get some air to that skin. Dr. Sonnenberg pulled the sheets down from the edge, revealing the synthetic blue plastic mattress, the layer of the blue plastic mattress, and he points to it saying, "Not breathable material." And then he points to my patient's skin. "Needs to breathe." Questions? I actually did. I asked, "How in the world, doctor, can anyone know one rash from the other and all its minute details to help figure out how we are going to proceed?" He tells me straight up, memorization, and, Dr. Tonis, don't try to fit the rash into your definition. Well, he was right. I tried to make what I saw fit into what I had already diagnosed the patient with, rather than assessing all of the details and then trying to find the best fit. By the way, this doctor was not a jerk by any means. It's just tough love. Ladies and gentlemen, I present to you a furuncle cyst. No, not a furry uncle cyst. I said furuncle cyst. We also call these boils. These are characterized by having a erythematous nodule that is extremely painful, and it occurs at a hair follicle. They are deeper than our typical folliculitis that we're going to see, and we also, if we ask a patient more about it, we're going to know that they are recurrent, and we're going to see scars probably adjacent or to the current one that we are looking at. Where is these furuncles going to be distributed? Well, they're going to occur on the buttocks, the thighs, the abdomen, and around the neck regions and axillary area. How does it spread? Ooh, touch, right. Particular nails from scratching or from the patient's attempts to pop it. It is commonly caused by Staph aureus, and if it doesn't respond to oral antibiotics and maybe a topical such as bacitration and antibacterial soaps, do suspect MRSA is involved. Now, illness can occur if the infection goes deeper into the tissue, and we'll get a lovely case of cellulitis. And very rarely, but it can happen, it will migrate into the bloodstream, and this is not going to be good because it will lead to sepsis and death. But generally, they are localized to the surface of the skin. What is a treatment for a furuncle? Lancet, yeah. And what I mean by lancet is a doctor will insert a blade and drain the pus. And sometimes they will remove the inner lining to help it not reoccur. What does a nurse need to do? We are going to cover it. We're going to wash it frequently. We may give a patient IV antibiotics or strong PO antibiotics. More than likely, they may even get vancomycin if the person tested positive for MRSA. And when I say wash it frequently, we are probably going to give a person a chlorhexidine bath, which is a strong chemical bath. And if it is painful, such as in the groin or the neck areas, a warm compress can actually help alleviate some of the discomfort. These little beauties are folliculitis. They are isolated erythematous pustules singly or in groups. As you'll notice, there is a hair at the epicenter of the lesion. There is little to no discomfort for these. There is little to no residual scarring. We're going to notice these distributed to the beard area and other hair-bearing areas, such as maybe pubic hair or even the axillary area. It could be on the chest as well. They are going to be caused by Staph aureus. Scratching or rubbing them with the fingernails can spread them even further. We need to apply topical antibiotics, possibly PO antibiotics. Really reinforce keeping somebody's nails very short and good hand hygiene. Do disinfect equipment well. such as if you're in the hospital and you have a stethoscope, disinfect that, please. We're going to keep the area covered and dry. This would be cellulitis. It's actually in the acute phase, as you can notice here, because there is intense erythema, or a lot of redness. That's fancy for a lot of redness. Okay, this is a generalized infection that is caused oftentimes by staph or strep, and it involves the deeper connective tissue layers. It can be a secondary bacterial infection of an open wound, maybe from trauma or maybe a furuncle, but it can also come from no trauma, such as chronic lymphedema. The area can enlarge its redness and distribution rapidly. In fact, if you were to touch it, you'll notice that it's very warm, it's very tender, and you'll notice that the skin is pretty edematous and, of course, red. Did I mention tenderness? Yes, okay, good. The cellulitis is often accompanied by fever and lymphadenopathy. This is fancy for nearby swollen lymph nodes are going to be enlarged, or nearby lymph nodes are going to be swollen and enlarged. One of my patients in the past actually came in with severe cellulitis of the lower extremities. Come to find out, when I was talking to him and trying to give him education about, okay, make sure you wear shoes when you're walking around so we don't have a reoccurrence. And he goes, oh yeah, I oftentimes walk barefoot in the chicken cage every day to get the eggs. Sir, you do what? Yeah, he said he walks barefoot in the chicken cage every day to get the eggs. And so I informed him that chicken poop is probably not a good thing to walk in with our bare skin, and more than likely it got into small little cuts into his feet, and which is leading us to this major case of cellulitis. And so recommend proper shoe wear when you go into the chicken cage to get eggs. And I shared that with the doctor. He agreed. Okay, so for cellulitis, we are likely going to put our patient on penicillin drugs. An example would be amoxicillin. We can also place them on cephalosporins. Or if they are allergic to penicillin drugs, we can give them drugs from the tetracycline family, the macrolide family, or the aminoglycoside family. We may even need to give them clindamycin, but do watch for diarrhea on this one, because we may have developed C. diff. This is an example of a MRSA infection. Specifically, this patient had community-acquired MRSA. If this is the case where somebody comes in with an infection, do a good assessment of their living conditions. What is their home sanitation practices? Do they have inadequate personal hygiene habits, such as walking barefoot in a chicken cage? Is there involvement with leisure or sport activities? Because we do know that gyms and sports equipment may be contaminated and shared amongst team members. Do ask if they've come in contact with maybe massage or stretching tables, or even nail salons. Do inquire if there has been a history of skin trauma or recent infections, which may have actually been the source of MRSA. If you notice a pustule is present, please swab the wound. We do recommend that you clean the wound first and then swab the base of it. If fever and malaise is present, take a blood culture, because in the blood we may actually detect MRSA, and if this is the case, we're going to have a poor outcome and need to do aggressive IV antibiotics. There is a chart in your book that talks about how to prevent the spread of MRSA. Please make sure to read that. When it comes to nursing interventions, we're going to change the bandage when the drainage seeps through. And we're going to rinse it on a daily basis, or even PRN if it's draining a lot more than that. Encourage your patient when they're at home to sleep in different beds than another person, and they can resume sleeping in the same bed when the infection is cleared. Do not allow them to share razors, towels, or other personal items. Encourage them to take all of their antibiotics and shower daily. Not a bath, shower. In fact, to clean their shower, they need to use hot water, Lysol, or bleach. Wear gloves and wash their hands when they are changing the dressing. The main priority is to focus on patient education and prevent infection to spread to the other areas of the body and to other people. If we're having the patient in the hospital, place them on contact isolation. If we are having to clean this wound, do remove the crust before applying your topical antibiotic because it can't penetrate otherwise. And to clean the crust off, you just get a moist, maybe a warm, damp cloth, and you lay it over there, kind of let it soak in, and then you can just wipe it off. Do not squeeze the pus out because doing so can encourage it to go deeper. Oftentimes, doctors will have to lance this and they leave it open for it to drain out. Area needs circulation to heal. So, well, what am I trying to say? Oh, okay. Keeping the dressing dry is really important because air will get to the wound bed and it will allow it to heal and dry out. Don't put an occlusive dressing on it, I think is the moral of the story. What's an occlusive dressing, you may ask? Tegaderms. Those are occlusive dressings. Gauze would be really nice. You're looking at a picture of someone who has shingles, also known as herpes zoster or varicella zoster virus. This patient will have vesicle lesions with an erythematous base that are in groups or clusters. They are going to follow a specific dermatome, and they are typically unilateral on the face and or the anterior or posterior trunk. There are going to be several days of discomfort with mild to severe eruptions of these vesicles. A patient before the vesicles erupt are going to complain of deep pain, itching, and burning. And then when the vesicles appear, this pain and itching persist. The eruptions can last several weeks, unfortunately. Patients also have to deal with something called post-herpetic neuralgia. This is when somebody has residual pain that lasts for weeks or months after being healed up. It is extremely common in older people to have post-herpetic neuralgia. We consider shingles to be very contagious, and you can get it in a number of ways. I'll list the 4. 1. You have had no history of chickenpox and you come into contact with a person with active shingles. Now you have shingles. Voila. Number 2. You have had a history of chickenpox, but your antibodies are too low, offering insufficient protection, and thus when you come in contact with a person with shingles, now you have shingles. Number 3, you have had only one of the 2 series of varicella vaccinations, thus offering insufficient protection, and now you have shingles. Number 4, you have had chickenpox as a child and your immune system lowers for a moment, either due to stress, chemo, some kind of biologics or immunomodulators, or you're on steroids. And then the virus could actually reactivate itself. And now you have shingles. For the management of shingles, we're going to make sure to try to vaccinate a person if possible. But do know that the vaccination called Zostavax is actually a live or attenuated virus, and we don't want to give any live vaccinations if a person is immunocompromised. This actually could lead to the development of shingles. Anyone who is older than 50 with a good immune system should get the Zostavax per the CDC guidelines. We're going to make sure to place our patient on airborne precautions if the blisters are present and open. When they crust over and there's no more weeping, then we can actually move them to contact precautions. Just FYI, I read recently in the CDC that when they crust over, you can actually remove all precautions, but I know in the hospitals we typically leave them on contact precautions. Anyway, some complications include the post-herpetic neuralgia, Bell's palsy. This is whenever you have paralysis of the trigeminal nerve and when it innervates, which is basically the eye, the cheeks, and the mouth. You can have eye infection, scarring, full thickness necrosis, and even blindness in the affected eye if we have shingles on the face and head, like our gentleman that you see here. Other treatments include administering an antiviral such as acyclovir, Neurontin or gabapentin, and prednisone. This lovely picture is of chronic herpes simplex infection. Herpes simplex virus type 1 classically appears on the face and the lips. Herpes simplex virus type 2 is typically genital. Yes, they can actually present on different locations, as such as in this picture. We have a herpes simplex virus type 1 infection. Now, typically herpes simplex virus begins as stinging or painful sensations underneath the skin, which are soon followed by vesicles, which then evolve into pustules, which rupture, weep, and crust. There will be a shallow erosion or ulcer present. What is the worst about these lesions is that if they are on the mouth, talking and or eating often reopens the wound, thus prolonging the healing time. People can come into direct contact with a lesion, or if they have been exposed to the respiratory droplets, can get it. Better stated, herpes simplex virus is contagious when the wound is open and even crusty. Chronic wound has that punched out appearance with the shallow erosions, and it can take months to heal. Auto-inoculation is possible, so you can transmit the wound to different areas of the body. So as you can imagine, please keep it covered. This person is at risk for a secondary bacterial infection. Some other nursing interventions include giving acyclovir or valacyclovir. These are antivirals that will be very useful in treating it. Now, for the herpes simplex virus type 1 that is classically on the face and lips, we can do a topical treatment called Abreva. This is not going to cure it, but it can control the outbreak by decreasing the number of active viruses in the skin, and this reduces the pain. We may need to also remember to apply a topical antibiotic just in case we are at high risk for secondary infection. This is a picture of herpes simplex virus on the mouth and lips. As you notice, these painful vesicles have a red base to it with the little shallow ulcerations. This virus typically is dormant in the nerve ganglia, and it comes out periodically during times of stress. Some examples of what triggers this to reactivate are dry lips, sunburn, trauma, fever, menses, and fatigue. As you can imagine, stress management techniques are going to be very helpful for this patient. The use of sunscreen, lip balm, and there's not really much you can do for the menses. Birth control usually does not affect that as much. Not considered a treatment. Dermatite infections can occur in the nails, which is going to result in a condition called onycholysis. Now, we're going to notice in onycholysis a thick nail plate, a heaped up appearance, hardness, and possibly splitting or nail fracturing. We also may notice that the nail plate is going to be separating from the nail bed. So, patients who are actually of advanced age, maybe they've had trauma or decreased arterial flow, can just naturally have a thick nail plate. However, if we notice that heaped up appearance, it's probably likely due to the fungal infection. If somebody has hard, thick nails, we need to make sure to trim them only after we have soaked them in warm water and we'd applied petroleum jelly to the nail, making them nice and soft. If a nail splits or has a fracture, this may indicate that it has been repeatedly exposed to water and or moisture, particularly the toenails. This is the case. As you can imagine, a solution would be to dry the feet out often. Now, nail plate separation usually occurs from the result of air pockets that develop underneath the nail. Dirt, keratin is going to set in. We're going to have a bad odor present. The nail appearance is going to be grayish, maybe white, and it's going to be opaque. There are multiple over-the-counter treatments for onycholysis. We may, though, if it's severe and resistant to the topicals, or maybe I shouldn't say resistant, but the topicals don't seem to be penetrating it efficiently, then we're going to move to the oral antifungals. The main one is ketoconazole. Dermatophytes can also infect our skin in addition to our nails. And the name of the skin infection really depends upon the location of the dermatophyte infection. Dermatophyte, there we go. If it's located on the head, we call it Tinea Capitus. Here you're looking at a localized patch of Tinea Capitus. Tinea Capitus, or the dermatophyte, is usually carried around on animals that go outdoors, such as pet cats or dogs, or hedgehogs. I don't know what kind of animal you have, but it's usually picked up from the soil and transmitted to a human. We can also pick it up if it has been on a commonly shared item such as a comb or pillows. We do associate Tinea Capitus with poor hygiene, so keep that in mind whenever you do your teaching. We are going to treat this patient with malathion and permethrin cream. A patient is going to complain, though, of intense itching associated with this condition, so do encourage them to apply over-the-counter medications such as calamine lotion. The prevention for Tinea Capitus: keep the skin dry, good hand washing, no sharing of personal items, clean your animals regularly, and good hygiene yourself. There. The most upper left photo there is an example of Tinea corpori. This is where we have a dermatophyte infection on the body, and it honestly could be anywhere on the body. The lesions are annular or serpiginous with elevated borders, scaling, and central clearing, meaning there's not much redness kind of in the center. They can present as one large patch or in clusters of small patches. Now, we still call it this, but sometimes people refer to this lesion as ringworm. Please know, there is no actual worm in the skin. These patches are just sometimes that perfect ring or circle, and I repeat, there is no actual worm in there. The bottom two pictures are an example of Tinea Pedis. We oftentimes will call this athlete's foot. Athlete's foot can either be wet or dry. Please inform your patient not to share items. They need to, such as shoes. They need to change their socks frequently. And if they are going to a public shower, wear shower shoes, because this dermatophyte is often picked up from the shower floor. For this, we're going to apply an over-the-counter topical either powder or cream. An example would be ketoconazole, which is generatively safe, and they're going to apply this multiple times a day. They're going to continue this for a few weeks, even after symptoms disappear. Now, what you see in the upper two right pictures are Tinea Cruris. This is where you're going to have a fungal infection in the groin area. A lot of times this is referred to as jock itch. An intervention for this, it would be to make sure to control moisture. One reason would be maybe men should wear boxer shorts over briefs, because briefs aren't as breathable. If you want to, you can apply a topical cream, not an ointment, but just like a water-based cream or a powder to this. I do have an example of somebody who has this of color on my upper right photo. As you can see, it's not that bright red look to it. It's going to be a deep, darker color, kind of a purple almost. All right, if we are wanting to really test for this condition and rule out that it's not psoriasis or some kind of eczema skin condition, we can do something called a potassium hydroxide preparation, which is done by skin scrapings or collecting skin scrapings, and then we're going to apply some solution to it and look at it under the microscope. This is a picture of Candida albicans, also known as thrush. Thrush is a fungal infection of the mouth. This is oftentimes a side effect of broad-spectrum antibiotics, or it can be present in people who are immunocompromised, such as someone who has an autoimmune condition, maybe they're on chemotherapy. You can actually distinguish thrush from poor oral hygiene by trying to scrape it off. Yep, by trying to scrape it off, you're going to know if it's just somebody that brushed their teeth and their mouth is coated, or it's an actual infection. In fact, if you could, please Google Candidiasis of the skin and describe the rash that you start to see. Where are you noticing it? Is it in the groin area? Is it in the axillary area? Or maybe under skin folds? Right, that's where the cutaneous candidiasis likes to show up, anywhere where it has a moist environment. How are you going to treat, we'll go back to the oral candidiasis, how are you going to treat it? Well, we can actually do an oral nystatin swish and spit solution, or we can swish and swallow it if it extends down into the throat. We're going to continue good oral hygiene practices, and if we do notice that the candidiasis is on the skin, we want to be sure to gently clean it, keep it dry. We can apply a nystatin cream or powder to the site. Be sure to be gentle, don't scrub. People are oftentimes going to report it feeling raw, the skin, or maybe even their mouth feeling raw. As far as the skin candidiasis or yeast infection, I've actually seen in the hospitals this new product called Interdry. It, to me, looks like a performance fabric, kind of that we would wear like Under Armour. And this fabric is actually cut to size, and it's placed in somebody's skin fold, and it's supposed to allow air to get to the skin. And you will leave this in, you'll pull it out every day, wash and dry it, and replace it. And I've heard that it could last for several days and several washings, but it's called Interdry. kind of neat. You can Google that too to look at Interdry and how to use it. Cutaneous anthrax is an infection caused by the bacteria known as Bacillus anthracis. Our typical risk factor for Bacillus anthracis is usually from animals that is infected with it. The people who are going to be vulnerable to this would be farmers, veterinarians, tannery workers, like people who work with leather, and wool workers. An infection begins like this. They begin to itch at the site, and then it starts to look kind of like a mosquito bite. Unfortunately, this mosquito bite is going to grow larger, and then it's going to develop a hemorrhagic center, and it's going to ulcerate. When this ulceration develops, the eschar is going to, as you see there, is going to develop, and we're going to have local edema. The lesion is going to be at this time painless. Now, how do you know this wasn't just a really bad mosquito bite? Well, mosquito bites don't ulcerate, and this one is going to be painless. You may have one lesion, or you could actually have several lesions in the same body area. Diagnosis is made from the features, doing a wound culture, and we can actually test somebody's blood for the antibodies. Do suspect bioterrorism if somebody is positive for cutaneous anthrax and they have not had exposure to animals. It's very, very odd. A patient should receive oral antibiotics, particularly Cipro or doxycycline, and they should receive IV antibiotics if they have edema or systemic manifestations. We're going to be giving these antibiotics over 60 days. That's a long time period. We're actually going to skip the oral antibiotics and go straight to the IV Cipro or doxycycline if they have lesions on the head, neck, or the person is pregnant. What you see in this picture is lice. Lice has another fancy word known as Pediculosis Capitus. If you have a single lice, it's called a louse. So Pediculosis Capitus is a louse infestation. This close-up picture is so clear you can actually count its 6 legs, and you can see these little egg capsules on the hair shaft known as nits. To be able to detect nits or a louse, you need to take somebody, ask them to flip their head over and look at the shaft of the hair, meaning near the base of it. We're going to see these little gray white things attached to their hair, and they are not easily removed, unlike if somebody were to have dandruff. There is intense itching associated with Pediculosis capitis, so do look for scratch marks and excoriation. Now, we actually can have an infestation of lice on the body, and if this is the case, it's going to live in somebody's clothes, particularly their hemlines. So when you look at a patient, look for places where their shirt has a hem or where their belt goes around their waist. For treatment of this, we need to wash all items in hot water, and we need to use a fine-tooth comb to get the nits and the lice out. Do not share any personal items. We need to shampoo hair with special lice chemical killing shampoo. An example would be permethrin cream, also known as Elimite. Get it? Elimite for eliminate? I like it. In items that can't be laundered, we're actually going to lock them up for about 2 weeks in a super sealed container. We're going to limit their social contacts for a few days as treatment has started, and we're going to continue to check somebody for 2 weeks. If the itching is pretty intense, we can use calamine lotion, over-the-counter calamine lotion, for their itching. Scabies are also another type of mite that a person could become infected with. Scabies mites are usually from animals, or they're from a person who has poor hygiene and has come in contact with another person who has scabies. If we were to look at somebody's skin, we're going to notice that they have these ridges, which are usually present from the little mite burrowing underneath the top layer. The patient's going to complain of intense scratching, so you're going to see some excoriations as in the picture on the right there. It is going to be worse at night, and we're going to find these burrowing and ridges along somebody's fingers, on their palms, at their wrist, which is a common place for the ridges to be found. To be able to diagnosis, they're going to scrape the lesion and look at it under a microscope. To treat this, we can either apply a topical shampoo or even a cream of permethrin cream, Lidane, or malathion. Please make sure to isolate this patient, use contact precautions. Oh, and you use contact precautions for somebody who has lice as well. And gown up, put a mask on, put your hair in it, and use booties on your feet. Okay, and back to scabies. Make sure to launder this person's clothing in hot water. Have you ever visited a hotel and thought to yourself, this room looks questionable in its cleanliness? Well, take a hint, because this discounted hotel room may offer you a bit more than free soap and breakfast. This is a bed bug. This flea-like mite is transmitted from travelers who go place to place and stay in the hotel rooms, and if they are not properly cleaned, we could very well have an infestation of bed bugs. These bugs like to live in cracks, crevices of like headboards, and they lay their eggs in soft upholstery materials such as mattresses or maybe couches and other wooden crevices, as I mentioned, such as the headboard or the frame of the bed. The bugs do come out at night and they feed on human blood, kind of like a flea would. Bites look like flea bites actually. There's going to be this little area of redness followed by like a red raised wheal. The degree of itching is sort of relative. However, if a patient complains of it, we can give a topical antihistamine such as Benadryl or diphenhydramine. We may need to do an oral antihistamine or even corticosteroids like prednisone. To be able to treat this, we actually cannot do it with over-the-counter pest control products. We need to call a professional. Sometimes the whole mattress and all of the furniture need to be removed, quarantined, and actually destroyed. All body areas are susceptible and bites may occur in clusters, or it could just be a single bite. Eczema is a skin irritation that often accompanies asthma or allergies. There's going to be a cycle of redness, papules, vesicles, and maybe even plaques. Eczema can appear in patches anywhere on the body, but is oftentimes on the hands and the feet. Patients often complain of it being itchy, not so much painful, but just itchy. If someone has eczema chronically and itches it a lot, we can develop something called lichenification, and they can also develop fissures. Lichenification is when the skin turns hard and leather-like. Fissures are when the person develops deep cracks in the skin. A picture I have on the left is somebody with chronic eczema of the feet. A person can, or the picture on the right is where somebody has pustular eczema. This is also known as Pomfolics eczema. To be able to treat this, a person needs to apply steroid cream. They need to have their skin stay moisturized. Anything over the counter will be okay. Well, when I say that, anything that is non-scented over the counter should be okay. They should avoid irritants such as scented creams or maybe even the sun and perfumes. Please do not apply the steroid cream to the face. The face is very sensitive to steroid creams. Now in eczema, we can actually apply the cream and then add a warm, moist compress to help it absorb a little bit better, but please don't apply an occlusive dressing over the steroid cream and then apply your more warm, moist compress. We do that intervention for only psoriasis, not for eczema. On the left here, you're looking at seborrheic keratosis. This is a common skin growth in people who are of advanced age. It's usually brown, black, or even light tan. The growth can look waxy, scaly, or maybe slightly raised. If you notice that it is growing in thickness, this may likely be a premalignant mole. And if this is the case, we know that it can turn into squamous cell carcinoma and we probably need to have it removed. On the right there, we actually see a keloiding scar. This is a disfiguring genetic predisposition where if somebody has a scar, it's going to grow and develop uninhibitedly. It is genetics, and doctors really try to refrain from cutting the scar, as what happens whenever you cut scar tissue. It develops more scar tissue. We can, however, do steroid injections or maybe apply some anti-tumor topicals. I have also known people to get laser removal and even cryotherapy to help reduce scar tissue. It's always a risk though, because scarring scar tissue can lead to more scars. The picture on the left is squamous cell carcinoma. Squamous cell carcinoma lesions are firm, nodular. They oftentimes will crust or have a sore present. They are raised or indurated. We're going to find these on sun-exposed areas of the body. The top right is an example of basal cell carcinoma. Basal cell carcinomas are pearly papules. They have a waxy appearance, a very well-defined border, and there's going to be presence of telangiectasis, these little spider veins inside there. The pigment is going to be flecked on very close inspection. Metastasis is pretty rare with basal cell carcinoma. Now, the bottom right picture is a variety of melanomas. Melanomas are irregular shaped papules or plaques, and they can be multiple colors such as red, white, or even blue. They can occur anywhere on the person's body, but do check the feet and the palms in dark-skinned individuals. This is a common acronym for detecting melanomas, ABCDEs. So I'm not going to read it to you, but just pause and sort of try to commit this information to memory because you may see it again later.